Then the others are on your guys' calendar and Canvas with the times and dates, okay? All of your exam review materials under exam 3 review schedule. Okay. You guys see the PowerPoint? Yes? No?
Yes.
Okay. There we go. Okay. So this week is GU and, oh, is my screen sharing not working? Here, let's resume it here. Okay. All right. So it's GU and dermatology. Okay. So skin conditions and GU. So kidney and urinary symptoms. Okay. Here are your objectives. Chapter 29 is GU. So no, have this kind of help guide your learning. Okay. So as far as urinary function, looking at that, you have to kind of know what's all involved. So obviously your kidneys, your ureters, your bladder, and your urethra are all involved in the urinary function, okay? So in looking at that to assess anatomically or for structural abnormalities, they usually utilize ultrasounds first line. They may do a CT of the kidneys. Usually they use dye with that, so you'll get that dye. And the thing about the dye is if somebody has a shellfish allergy, to not utilize the dye because there's the potential that they'll also have an allergy to that CT dye contrast, okay? An IV pilogram, which that utilizes dye as well, that looks at the kidney filtration of the dye specifically. A cystoscopy is where they put a little camera into the urethra and look at the bladder. Okay. And then avoiding cystourography, which is very similar. It's going to be a little camera while they void and looking at kind of the flow and if there's residual urine left over in the bladder after they voided. Okay. So anatomically in kids, kidneys are more susceptible to significant injuries from trauma, just because they don't have as much fat padding, in their abdomen and kind of on their backside that, adults do. So they're more at risk for if they have an abdominal trauma or a trauma to their back, to having kidney issues. Full kidney function isn't until about 2 years of age. So that kind of goes along with, when kids are ready to potty train as well, okay? Just know all of these. I'm not going to go, obviously a UA, you just, have a clean catch UA to check for infection. A biopsy would be looking for, cancerous or abnormal cells. So commonly used terms, be aware of these terms, okay? Dysuria is discomfort or burning with urination. Frequency is, you're having to go pee frequently. Urgency would be you have to go, the second you feel like you have to go pee, you have to go. Nocturia is waking up in the night to go pee. And uresis is having accidents, urinary accidents, whether it's at nighttime, nocturnal enuresis, or diurnal enuresis, which is during the day. Polyuria is urinating frequently and a lot of amount. And oliguria is minimal urination. Okay, So some anomalies of the urinary tract phimosis. So this is a narrowing of the foreskin opening. You can see that right here. So it prevents this foreskin from being retracted back over the penis. It has to be corrected by circumcision. They used to say people would try to forcefully retract that back, but that should be avoided because it can cause paraphimosis, which then you can't retract it back at all. And then you worry about the circulation. It can't ever return, like if you forcefully retract it back, it can't ever return back to its normal position. And a lot of times you'll have swelling and impaired circulation because of the constriction. So shortly after birth, if phimosis is identified, then this kiddo will need a circumcision. Epispadias and hypospadias. So epispadias is when the urinary meatus or opening, okay, is on the upper surface of the penis, okay? So on the top side, so this is epispadias. Hypospadias is when the urinary meatus, the opening is on the bottom or the underside of the penis. Okay. Might also have chordae, which is a curvature of the penis because of fibrous bran tissue. So you might also not only have an abnormal urinary meatal opening, but also kind of that curvature to the penis as well. If it's a minor case, so say that the opening is still on the head of the penis, but it's, not center, they may not need surgery. But if it's on the so if they have epispadias or hypospadias and it's significant, then they'll need surgery. Usually they do the surgery before 18 months of age. And that's because the hopes that then that doesn't affect their potty training development. Okay. They will not do circumcision routinely in these kids because they utilize the foreskin to then kind of help with the repair. So if parents want kids circumcised, they'll do this repair first and then they'll do the circumcision. Okay, exstrophy of the bladder. So this is when the lower portion of the abdominal wall and the anterior wall of the bladder are missing. So they begin to develop outside of the abdomen. Okay. So you're actually seeing, here's the urinary bladder itself. It's, developed outside of the abdomen. So urine's going to continually leak from this area, okay, and the skin is going to get really broken down and excoriated. You'll have to protect the urinary bladder in a protective mucosa. So you'll have to, usually they kind of have like a moist kind of dressing around the mucosa of the urinary bladder. So that way it doesn't dry out until they're able to have the surgery. Surgery is usually performed within 48 hours after birth. You will want to have these babies positioned on their side or on their back so the urine's just draining freely, kind of. The diaper is under the infant instead of up and over the bladder, okay? Like I said, urinary repair on that is within 48 hours of birth usually. An obstructive uropathy, so tumors, strictures, which is narrowing, scarring, or renal calculi, which are kidney stones. Those are all options of obstructive uropathies. So hydronephrosis is an enlargement of the kidney that happens after any of these things. So if there's a tumor, on the ureter area, that urine's going to backflow to the kidneys, so the kidney's going to enlarge. Polycystic kidneys, so if there's a bunch of cysts on the kidneys, that's also potentially a form of a obstructive uropathy. So there'll be a bunch of cysts on the kidneys. That kidney's not going to function as it appropriately should. So if the obstructive uropathy is significant enough, then they need a urinary diversion surgery. So they'll need a urostomy created. So you can see here, they took the ureters, and instead of having them go, down to the bladder like it should, it's coming to this stoma or this urostomy opening, okay? Yeah, so there's a question about if voiding works the same way positionally with the extrophy of the bladder. Yes. So voiding, they'll still be able to, we'll go back here. They'll still be able to urinate normally. It's just the urine's just going to drain out because it doesn't have an actual opening like it should until after they have the surgical repair. So keeping them on their back or their side so that way the urine can drain appropriately out. Toddlers, if they have an obstructive uropathy, they likely will not be able to be toilet trained. And especially if they wind up having to have a stoma placed or urostomy placed, then obviously they're not going to be able to toilet train like everyone else. Sometimes after obstructive uropathies, they can do a revision and, reattach to the bladder normally. But sometimes the only option is the urostomy. School age kids, they might also start to have, distorted body image later, school age kids, or feel like they're different from other kids. And then, of course, self-esteem and concerns about sexuality in adolescence if they have an obstructive uropathy that's led to a stoma needing to be created. UTI, so this is more common in girls. They have shorter urethras. The urethral opening is located near the anus, so there's more risk for, if they wipe back to front instead of front to back, that they can get a UTI, most commonly caused by E. coli. Close fitting, tight clothing, specifically underwear, nylon underwear, that more slicky underwear is more likely to cause irritation. Bubble baths, retaining urine, so not getting all of that urine out when they go pee, or vaginitis, so an inflammation of the, an irritation of the vagina can also contribute to UTIs. So usually you talk with younger girls about making sure that they wipe front to back, that they're not, sitting in bubble baths often, that they're making sure that they get all of their urine out before they, go finish playing whatever they were doing. Normal urine is acidic, so if the urine becomes alkaline, it's more likely that those kids are going to get a UTI. Okay. Some terms to know: pyelonephritis, so that's a kidney infection. Urethritis is the urethra is irritated or infected. Cystitis is going to be the bladders infected, the infections in the bladder. Ureteritis is those ureters are going to have the infection. Bacteria is going to be bacteria in the urine. And vesicordial reflux means that essentially when that kiddo is going pee, they're not having all of that urine drain out. And so then that urine's just hanging back up and refluxing back to the kidneys. Okay, so critical thinking question. So 11-year-old girl has been diagnosed with a UTI. What are key points that the nurse should teach the patient and her parents about treatment of the condition? You guys can just unmute.
That is treatable, wear cotton underwear, and don't take bubble baths. Proper wiping techniques.
Yep, making sure that they're wiping front to back and wiping themselves all the way dry. That's another thing I see too. Kids are just in a hurry, so they just kind of dab quick and then run away. So that's another cause. Also, kids are really constipated, their bladder can't empty appropriately. So making sure that they're having regular stools as well, because otherwise they can have some urinary retention from that as well. That can cause UTIs. What else? What are they going to get if they have a UTI? Are they going to get a medicine or?
Take all the antibiotic till finished and maybe
Yes.
drink some cranberry juice or apple juice to make their urine more acidic.
Yeah. Yeah. Good. Good. All right. So nephrotic syndrome or nephrosis. This is a kidney condition where there is a lot of protein in the urine, and it causes edema and low albumin in the blood. It's more common in boys, specifically kids 2 to 7 years of age. So thymus T cell dysfunction, they think is a part of why some kids get nephrotic syndrome and some do not. So the treatment is utilizing steroids in these kids when they have high protein and they're edematous, like, so they'll have facial edema, hand edema, like, peripheral edema, and also then low albumin. These kids, a lot of times too, if their albumin's really low, they may also need albumin transfusions. Supportive cares, nursing wise, and like I said, keeping track of weight, urinary protein levels, and then obviously any medications that these kids need, making sure that you're letting parents know that they need to be on top of giving those medications. When they are in a nephrotic syndrome kind of flare up, or when this is going on, they should not be getting any vaccines or immunizations, okay? Because they're likely going to be on steroids, which is going to suppress their immune system. So those vaccines that they get during that time, they won't have a good immune response to. Positioning to help reduce the amount of edema, and then strict I&O. So anything that these kids take in and have for output needs to be meticulously kept track of. Daily weights, and then obviously preventing infection as well. Since there's that T cell dysfunction, that's a part of it. They're going to be at more risk, plus they're going to be on steroids, which is even more risk. Glomerular nephritis. So this is something that happens typically after group A strep infection. So kids get strep throat. They don't take all of their antibiotics because they're feeling better, within a few days. So they stop taking their antibiotics. And then they kind of have this antigen antibody allergic kind of reaction, or essentially the antibodies start recognizing those tissues, those glomerular tissues, as kind of a foreign or an attacking agent. So then they start attacking, those antibodies start attacking the good glomerular tissue, which then causes inflammation. Okay. So both sides of kidneys are usually affected in glomerular nephritis, and generally it resolves within a couple of weeks. Not something you have to do a whole lot about, other than finish the antibiotic for strep. Like I said, it's kind of like an antigen antibody misregulation reaction. Okay, so a 4-year-old boy explains to the clinic nurse that for weeks, or the parents of the 4-year-old boy explained to the clinic nurse that for weeks the child has been irritable and listless, and he has even developed a poor appetite. He's gained weight. What signs and symptoms should the nurse look for, and what would you expect? So let's start with, what symptoms are they reporting, and kind of what's being suggested that this kid may have.
That he's irritable
Uh-huh.
and that he has a poor appetite and he has gained weight.
Uh-huh.
That's what's reported. Would it be nephrosis is the condition?
Nephrotic syndrome. Yep. 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 That's what it looks like they're looking for. So what are some interventions you are going to do, and how are you going to educate those parents?
So to just monitor his I's and O's
Mm-hmm.
and just be supportive.
Uh-huh. And they might be on steroids, right?
Right.
So you might have to give them, the steroids and make sure parents know about keeping track of that. Also, their weight gain, right?
Mm-hmm.
And monitoring their swelling. So they might need some position change kind of things. Yeah, good. Anyone else have anything to add?
Oh, and like no immunizations if they're on steroids?
Yes, good. That's an important one. Good. Okay. Wilms tumor. So this is a form of cancer, okay? The tumor is usually within the kidney, okay? It's diagnosed by a pilogram. So that tumor is going to be attached to the kidney and it's kind of pushing down on the kidney. That tumor also usually is encapsulated, so it's enclosed as well, kind of within the kidney. These kids are going to have high blood pressure almost always. If you know that your child that you're caring for has Wilms tumor, do not push on their abdomen. That is a huge no-no because the Wilms tumors, they're so fragile that they'll actually with palpation, they'll kind of flake off into little pieces, and then you can see that tumor then start to grow in other parts of the abdomen. Okay. So do not palpate the abdomen. So if you get a kiddo in that's just diagnosed with Wilms tumor, it would be best for you to make a sign that says no abdominal palpation. Okay. Treatment for Wilms tumor is going to be typically surgery, radiation, and chemotherapy. Okay. They may remove that affected kidney as well as the tumor. They try to do that usually as soon as possible after diagnosis, just so that way it's less likely for that tumor to metastasize to other areas. Okay. So nursing care wise, obviously knowing that they're going to be having surgery, you're going to have to do pre-operation kind of preoperative prep work. So putting in those IVs and getting their vitals and making sure that all looks okay. Also sharing with the parents to not be pushing on their bellies. And then you're also going to do routine post-operative care. So you're going to do your frequent vital signs, monitor for bleeding, looking at the surgical sites for infection and all of that. Okay. And as far as the chemotherapy and radiation goes, nursing wise, obviously those who are receiving chemotherapy are immune suppressed, so they're very likely to get infections. So trying to prevent infections in these kids. So if a kiddo with Wilms tumor is on chemotherapy, they've just had surgery and they have a fever, that's very, very concerning. So, okay, hydrocele. So this is an excessive fluid in the scrotal sac around the testicle, okay? So, you can very easily see that there seems to be some fluid in this, on the scrotum on this side. So if kids have hydrocele that lasts for longer than a year of age, then they go in and correct that. You can see hydrocele happen after trauma to the scrotal sac. In some cases, usually that's in older kids, so they have that intervention more quickly. Okay, but if you have a baby that's born with hydrocele, then usually they wait until a year. Okay, cryptorchidism. So this is when the testes fails to descend into the scrotal sac where it belongs. Usually it's one side versus both sides, but potentially both sides can also not descend into the scrotal sac. So with the testes staying in the abdomen, you're gonna likely see those spermatic cells are really gonna be affected. They're gonna have a harder time with fertility, you know, down the road if that's not resolved. If both testes are involved, so both the testes do not descend into the scrotal sac like they need to, then these kids can become sterile. Okay. Usually they also have an inguinal hernia. So that testes then is kind of protruding through the inguinal canal, or a portion of the spermatic cord or something is also protruding through that inguinal canal, which then leads to an inguinal hernia. So that also needs surgery to repair. Okay. The testes continue to secrete the hormones into the bloodstream. Okay. So secondary sex characteristics are not affected. So those hormones are still secreted. So kids will still progress through puberty. They just are more likely to have effects on their fertility. So they'll have surgery to go in, take that testes and place it to where it needs to be. Also with cryptorchidism, if kids have cryptorchidism, they're more likely to have testicular cancer as well. Okay. So the impact of urinary or genital surgery, obviously, typically if it's happening between 3 and 6 years of age, there's more curiosity about differences in the sexes. Okay. So it's okay to be aware that there's differences in the surgical interventions may also then delay toilet training. Okay. So depending on the age that the surgery has to occur. That's why the goal is that they do those surgeries before we're progressing to toilet training, so we don't have a regression. Okay, so chapter 30, skin conditions. Know these terms, okay? Help these objectives kind of guide your studying, okay? Okay, so the main function of skin, this is your first line of defense, so is protection, right, from outside pathogens or chemicals or harmful agents. Also preventing water loss and loss of electrolytes, okay? Skin can obviously regenerate and repair itself. You get a cut, a scab forms, and then the skin repairs from, you know, the inner part of the skin outward, and then that scab falls off and you have that new skin in place. So skin conditions may cause systemic disease. Okay, so the kids may have a skin condition that affects, you know, not only their skin, but other body systems. Okay, this may be something that they're born with, so it may be congenital. It may be a genetic kind of factor with skin condition. Okay. Skin color is also an important criteria, diagnostic criteria in certain diseases. So skin color can affect how like eczema and other skin rashes look, you know, on different skin tones. Okay. Skin tests. So this is where they look at allergies to diagnose allergies. They typically do the skin test on the back. They have multiple little antigens that are poked into your skin, typically like common environmental allergies, so like grasses, molds, trees, and then like animal allergies, so cats, dogs, horses, cows, things like that. And then they inject that little bit of that allergen into your skin, and then they wait a few minutes to see if you wind up having a wheal or a hive to that antigen or that allergen. And then that's how they look at diagnosing allergies in kids. That's the most common and most accurate way to diagnose allergies. They do have blood tests that you can do, but those aren't as accurate. Okay. Hair, obviously, that goes along with skin conditions. So inspecting color, texture, quality. There's a disruption, if kids start having their hair fall out, then that may be an indication of those kids not getting good nutrition, or they're beginning to be a disease process like thyroid dysfunction or something that's occurring. Okay. Hair can also change because of medications or medical treatments. So most commonly, probably people think of chemotherapy, right? Eventually our hair falls out from chemotherapy. And then once we're done with chemotherapy, it can grow back. Sometimes it grows back differently, but there's also some supplements and things over the counter that can affect hair and cause changes in texture or growth. So a sty, we'll start with that, or hordeolium is the other term for that. That's inflammation of the sebaceous gland of the eyelid. So it's more common in infants and children than adults. And you can see it just gets really large and swollen and red. It can be painful. Usually it's only painful though when it's being kind of pushed on or messed with. These resolve on their own. You can use some like heat, like warm compresses to that area to kind of speed up the resolution. But no need for like eye drops or antibiotics. Now, obviously, if the redness is worsening, into their upper eyelid as well, and they're having orbital swelling, so around their orbit, then that might necessitate an antibiotic. But if it's just kind of right in that area of the sty that's red and irritated, then there's no reason for an oral antibiotic. Strawberry nevus or a hemangioma. Okay, you might not notice them right away after at birth. Sometimes those dilated capillaries need to kind of continue to dilate to be able to see that strawberry nevus or that hemangioma. Usually starts flat, but then it can become raised and red and bright red. And then it can have like really sharp demarcations, which means like the lines are kind of like really wonky. Okay, and you can tell that this kiddo's had like laser treatment on this nevus. So usually it gets better without treatment, but if it's really large, then they'll do some laser treatments, or they'll do some topical medications that reduce the appearance of the hemangiomas. The other thing with hemangiomas, if kids have multiple hemangiomas in different places in their body, that might be suggestive of a disorder. So those kids will need some more workup and probably need to see hematology to make sure that they don't have a hematologic condition as well. But if they just have one or two hemangiomas, then usually not super duper concerning. Obviously, the appearance can be concerning to some kids. Port wine stains or port wine nevuses, that's what this girl has. So this is present at birth. So at birth, you will notice these. It's caused, once again, by dilated capillaries. These stay flat. Okay, these do not raise. They stay flat. They can be pink to purple. They kind of look like bruises. This does not go away. and it will become larger as darker as the child gets older. This is treated with laser treatments most commonly if they want to do treatment. Usually with dermatology does that. Okay. Adolescent female has a port wine stain or a port wine nevus since early childhood and now has significant acne. She doesn't understand why she is susceptible to these skin disorders and asks whether she has done something wrong. How would the nurse respond, and what advice would you give her? So does she have the acne because she has the port wine stain?
No.
No. It's because she's an adolescent, right? So she's going through those hormonal changes. Now, if you already have kind of a skin irritation or those capillaries are already irritated, you are going to be at more risk for other skin conditions to develop. But it's not because she's done something wrong. So what advice would you give her for her acne?
I would refer to her diet because I know adolescents they struggle with nutrition that could help.
Yes.
And I don't know if it's like judgmental to add that the port wine stain is like a non-harmful congenital thing. I would not, because then it's like, not like it's just something that happens before birth and like considering a lot of other things that could, it's just harmless.
Right.
They're not
Right.
related.
Right. Right. Yep. What else? For kids who have acne, what usually is a part of treatment for acne? Think back. Did any of you guys have acne as an adolescent?
It's like the acid cleanser, like the
Yep.
glycolic and astringents.
Salicylic acid. Yep. Yep. So face washes. So making sure that they're washing their face morning and night with the salicylic acid face wash. Or benzoyl peroxide is another one, but that one seems to be more drying. Okay. So washing with that. Also, if their acne is really severe, sometimes they'll get on a like a antibiotic face wash or cream that they utilize, as well as the salicylic acid face wash. If it's really, really bad, they might be on an oral antibiotic for a period of time for their acne, as well as washing their face. Okay. So you would give them the same treatment. Also, what do you think about sunscreen? Do you think kids with port wine stains or with hemangiomas need sunscreen in those areas, or do you think you should avoid it?
I think they still need it.
Yes. Yep. Yep. Good. Okay. Cafe au lait macules. These are light brown oval patches. Okay. They are, here, I can maybe show you mine. I don't know if you guys can see it very well, but it is, okay, so you can kind of see like it looks just like a birthmark, right? But it's a lighter, flat. It's always this color. It hasn't gotten darker, hasn't changed. Can you guys see it okay? So that is what a cafe au lait spot looks like. So if you have multiple of those cafe au lait spots all over your body, so like some kids will have just one, and then there's not really a huge deal about it. But if they have more than one or multiple of them, then you worry about neurofibromatosis. which is a chromosomal abnormality. And then also you worry about tuberous sclerosis, which is an autoimmune condition. Okay. So if you see kids and they have multiple cafe au lait spots, then they need to be seeing neurologists usually, and genetics. Okay. Hypopigmentation or hypopigmented macules. So macule is flat. Okay, that's what that word means. So this will be an area of like decreased pigment in on the skin. If you have multiple areas, then you worry about tuberous sclerosis. They can be leaf shaped, they can be oval shaped. They're usually kind of a white pigment because they're lacking the skin pigment or the melanin in that area. Butterfly rash, so you see that most commonly with either photosensitivity or with lupus. Okay, so they're going to have bright red across their nose and through both facial cheeks. Okay, like I said, so if you see someone with a butterfly rash on their face, it's usually not, it can be excoriated, so it can be irritated and open, but usually it's just kind of, they constantly are bright red. Okay, but that's going to be suggestive of lupus. Okay, scalding skin eruption. So this is can be associated with zinc deficiency, but a lot of times they get some papules, so that's a raised rash, and then the scaling, which looks like scabs, usually kind of cheeks, mouth. It can also be around the anus. Okay, usually kind of horseshoe shape. And a lot of times they'll become infected with our healthy skin flora. So staph and strep that occur naturally on our skin, in our skin flora. These papules and scales open up. So then that staph and strep go right into those openings in the skin. And then that's when you get like impetigo and skin infections like that that need treated with oral antibiotics or with topical antibiotics. But scalding skin is usually from a zinc deficiency. Okay. You'll see this rash plus failure to thrive, so they're not going to be gaining weight and growing appropriately, and also diarrhea. Okay. Vascular birthmark. So this is like a bruise that can kind of change in appearance over the years. So hemangiomas go along with that. Okay. But also if they're sacral, so they're kind of on your back, your lower back, those are called Mongolian spots. They're more common in Latino or African American and Hispanic kind of populations. So it almost looks like they have bruising on their lower back, but that's just a birthmark, a form of a birthmark. Okay. Like I said, hemangiomas, they can be problematic if they're in certain places. So if they're over your lumbar spine, you worry about spinal issues just because of that capillary accumulation in that area. Same with like if it's around the chin or like on the neck, you worry about problems with the airway. So if you see hemangiomas in those areas, even if there's just one in those areas, then you need to be sending those kids to hematology and dermatology. Okay. Okay, miliaria. So this is prickly heat rash. Okay, so this is excess body heat and moisture causes prickly heat rash. So these are going to be papules, so raised red, teeny tiny heat dots all over the body. Okay. Not a whole lot to do about it other than, make sure that you kind of reduce that body heat and moisture. And then that rash should resolve. Enorigo, so this comes from chafing. So if you've seen babies who have a lot of rolls, you can see kind of chafing or red irritation in those rolls, and that's enorigo. Sometimes if it really gets opened up from chafing, once again, you can see that staph or strep or yeast, that's naturally on our body, go in there and start an infection. So they may need an antibiotic or an antifungal in those areas. Once again, try and keep those rolls clean and dry as best you can to help reduce that risk of enorigo. Seborrheic dermatitis. Most of you guys have probably heard of cradle cap. So that's on their scalp, but it can also be on their ears and kind of come down to their forehead. With seborrheic dermatitis, you want to make sure parents are not doing things like olive oil or coconut oil to that area, just because those can potentially block those pores worse. So if they're going to use anything to try and improve the cradle cap, use mineral oil or baby oil, and then a soft bristle hairbrush. So put that baby oil on, let it soak for a little bit, use that soft bristle hairbrush, kind of scrub, and then have them wash their hair. Otherwise, they'll be really greasy. Okay. Cradle cap will eventually go away by itself. It can affect the hair development underneath where those scaly scabies are. So some parents want to just try and get rid of it as quickly as they can. Diaper dermatitis. So this is an infection of an irritation of the diaper area. So diaper rash can be caused by staph, strep, or yeast. So usually bright red, angry, beefy rash. If it looks the exact same on both sides of the diaper area and it has little tiny flat pinpoint red dots, that's more suggestive of a yeast infection. Okay. Acne vulgaris, that of course is your classic acne that occurs in adolescence. We kind of already talked about making sure that they're washing their face, keeping their face clean in that sense when they're having an acne flare-up. Herpes simplex virus. So there's type 1 and type 2. Type 1 is typically the cold sore or fever blister type of herpes. Type 1 can become genital herpes as well. But type 2 is kind of the classic genital herpes lesions. Okay. Cold sore wise, fever blister wise, there's not really a whole lot that you can do. Sometimes they'll have antiviral medications like Valtrex or valcyclovir or acyclovir that people can take as soon as they start to notice a cold sore happening. And they've had a history of HSV1, okay? But most of the time, herpes, cold sores, they start and then they kind of go away. Now, fever blister goes along with herpes simplex, can be. Those usually flare up, in times of stress or with illness or with fever, okay? Eczema. So atopic dermatitis is another form of eczema, another name for it, okay? This is hypersensitivity of the skin, but a lot of times these kids also have systemic involvement as well. So like a lot of times kids with eczema have really bad allergies. They're also more at risk for asthma to develop, okay? So you rarely see this in breastfed infants until they start eating other foods, okay? Most common food that causes eczema to flare up or to be worse is dairy, Okay. So if kids are eating a lot of dairy, that's usually a conversation that I have with parents is, cutting back on dairy. It's always worse in winter because their skin's more dry and irritated. Okay. You can try and figure out if there's a certain allergen that these kids have that's causing the atopic dermatitis to worsen. So these kids will likely see an allergist, okay? Ointments are better than creams. They're absorbed better, okay? And prior to putting on another layer of ointment or another layer of cream, you want to wash that off, okay? Cortisone or steroid kind of creams should not be utilized just because it doesn't resolve what's causing the eczema to flare up. It just helps with the redness and irritation. Okay. So kids with eczema, you want to make sure you tell parents once they're done with their bath, make sure that they had a warm bath, okay? And then they should not totally dry off. They can kind of drip dry a little bit. And then you're going to put their topical medications on in the direction that their hair grows. That's how it will be absorbed the best. Like I said, ointments are better usually than cream. So usually ointments are utilized. If infants are really scratching at those areas and then causing, open sores from the eczema, then sometimes they'll use elbow restraints or little like mittens. So that way they're not scratching at those areas. Topical steroids should not be used if there's a viral infection present, just because once again, you get concerned about the immune function if they're on topical steroids, just like with oral steroids. Also, if kids are getting steroids, topical steroids, and there's yeast involved, the yeast is going to get worse. So things are going to look worse. So at that point, then you would stop the steroids and do an antifungal or an anti-yeast medication, usually topical too. Okay. Another critical thinking question. A mother comes to the clinic with her 1-year-old child who has visible infantile eczema on his face. She remarks that she can't have his pictures taken because of the visible lesions and asks how long they will last or what she can do to eliminate them. What would be an appropriate nursing response to her concerns and questions?
So ask about diet
Yep.
and teach about skin routine, that baby has to have warm baths, not to pat dry, put lotion, topical medication when the skin is a little bit wet,
Yep.
and hydrate.
Yep. Hydrate the skin. Yep. Yeah, and what about her asking how long it's gonna last? How long do you think eczema flare-ups last usually? Do you think that there's like, okay, it's gonna be gone in a week?
I was just about to say that, like a week or two.
So it depends on the time of year, right? Because if it's winter time, the kids are going to be way more susceptible to it lasting forever. It also depends on if they're having a lot of allergens that's causing the eczema, because if they are and they're still being exposed to those allergens, then their eczema is going to continue to flare up until they're no longer being exposed to those irritating things that are causing their eczema to be flared up. So there's not really a great answer. Usually with good treatment, so like being really diligent about your ointments and your creams and all of that, keeping things moisturized and not doing dairy or keeping those kids away from the allergens, usually 2 or 3 weeks, I would say, for that to start to be improving. Okay. If kids are on steroid creams, remember, just like oral steroids, those need to be tapered. So kids won't just be on steroid creams for like ever. They usually do like 3 to 4 times a day for a couple of weeks, and then 2 to 3 times a day for a couple of weeks, and kind of wean down until they're not using it every day any longer. Okay. Okay, staphylococcal, so a staph infection. This is a common infection. Like I said, staph occurs naturally. It's in the natural flora on our skin. So anytime we have a cut, it's very opportunistic. That's one of the first things that want to kind of get into that cut and cause an infection. Okay. Newborns may get staph infections in their, around their umbilical cord, where that was, or also around their circumcision. So making sure that you're keeping an eye on that while they're in the hospital. And then telling parents to keep an eye on that while they're discharged. Obviously, if the area starts to get really red, have a smell to it, or is having abnormal discharge, then those would be, or fever, of course, those would all be signs of potential concerning infection. Okay. If infections are not caught early enough, then obviously that staph can enter the bloodstream and cause sepsis or septicemia. Okay. If you see a small pustule on a newborn, period, like it needs to be reported immediately, because you get concerned about, is it staph? Is it like herpes, right? If it's a herpes lesion, potentially. Usually herpes lesions will be more like vesicles, so vesicular, so they'll be more like a blister, whereas pustules will have pus within that lesion. Okay, but any abnormal skin things in a newborn, you need to be letting that provider know so they can look into it further. Antibiotic ointments are usually what's used if it's just a superficial skin infection of staph, but if it seems like there's concern of septicemia, then these kids will be on IV antibiotics. Okay. If they're tested and they have MRSA or MRSA, methicillin resistant Staph aureus, then those kids will always be in contact isolation anytime they're hospitalized until they test again and it's negative for MRSA. And that's purely because you don't want to be spreading MRSA to everyone else in the hospital. Okay. Scalded skin syndrome. So this is caused by Staphylococcus aureus. So MRSA can cause scalded skin syndrome. The lesions they are kind of mildly red or erythematous, and they kind of have a little bit of a sandpaper texture, so they're going to be red raised, and then they'll start to look like vesicles. So then you'll start to see those blisters, and then as those blisters pop and rupture, then you'll start to see that peeling happening. And then as you see that peeling occurring, that's when you're going to see bright red surface. So those vesicles, they'll pop open and then they'll start peeling. And then you'll see left over is a really bright red surface area where that vesicle was. So it looks as if that child, has a burn and their skin got scalded. Okay. So because of those appearance, a lot of times being circular and having bright red surface, you get concerned about child abuse. Like, is this kiddo having cigarette burns on them or something like that? So, be cautious in making sure that it isn't a staph infection. But obviously, if you have concern for child abuse, that needs to be reported because we're all mandatory reporters in healthcare. Okay. So report that, but also check into that they may have scalded skin syndrome from staph. Okay. Usually these all heal up and they don't have significant scarring after scalded skin. Okay, impetigo. I kind of mentioned this already. Like I said, impetigo can be caused from staph or strep, usually group A strep. So bolus form, so this would be like the, let me see. Oh, right here. So right here, this lesion that kind of looks like a little blister, that's called a bolus. Okay. And then there's non-bolus form, which this picture is kind of showing you more non-bolus form impetigo. So this didn't start, this kind of just started as a scabby little crusty lesion instead of the bolus. So bolus form is most commonly in infants, and it's usually indicative of a staph cause, whereas non-bolus form is more common in children and young adults, and that's usually more strep related. Okay. Infants are more susceptible because their skin bacteria, like they don't have a lot of great skin flora yet, especially if they weren't born via vaginal route, because then they didn't get that introduction of the vaginal flora on their way out. So kids can become more susceptible, infants can become more susceptible to impetigo. It's very contagious, especially if another person that's caring for this kiddo has open like a cut or something on their skin as well. And if usually they're going to get topical antibiotics, but for something this significant that's in multiple areas, and you'd have to use like almost an entire tube of the topical medicine, you will do oral medication. And if the oral medication isn't helping and they have a fever and they are seeming pretty sick, then they'll get IV or parenteral antibiotics. Okay. So with the antibiotics, you would want to cover for what? To bacteria. Because impetigo can be caused by two different things, right?
Strep and staph.
Yes. Yes.
Strep,
So
group A strep, right?
group A strep
Yeah.
and staph. Yep. Yep. So you want to make sure you cover with an antibiotic that covers both of those things and not just one or the other. Okay. So you're going to need a more broad spectrum antibiotic for these kids. Fungal infections. So tinea, right? We've heard of tinea, like ringworm, right? So tinea corporis is something, ringworm that happens on the body. Okay. And it's going to be circular, and then they'll have kind of a clearing in the midline or in the middle of that circle. Okay. Tinea capitis, so that's fungal that's on the head. Okay. You'll see alopecia, so you'll see hair loss in that area, and you should still kind of see this similar kind of ringworm-esque rash. Okay. Tinea can invade the hair and the nails, okay, and those hair follicles. So depending on where the fungus is, so hair, nails, all of that can be affected by the fungus. Okay. Tinea pedis, so that's probably like your athlete's foot. You guys have mostly all heard of. Okay. These are lesions between the toes or on the soles of the feet. They're very, very itchy. So fungal infections are very itchy. Okay. And tinea curis is jock itch. So this is fungal infection in, their genital area. Okay. So if any of these lesions, like I said, are over nail beds or very close to nail beds, you're going to see those nails be affected. So they might start being like more of a yellow color, or they might start even peeling off. Okay. Fungi or fungal infections are larger than bacteria. So they need treated with not an antibiotic, they need treated with an antifungal. So like Lotrimin or clotrimazole, those AZOLE is the last part of those medications. Those are all antifungal medications. Now to diagnose fungal infections, you can actually take a little scraping of the area and put it on a plate, and then the lab can look at it under a microscope and can confirm whether or not it is fungal. Okay. All right. Pediculosis or head lice. This as soon as I start talking about it, my head's going to start itching. Your guys' heads might start itching. It's just like the thing that happens, I feel like, when we start talking about head lice. But pediculosis capitis is classic head lice, okay? Pediculosis caporis, so just like capitis with tinea, caporis with tinea, that's just telling you where at it's occurring, okay? So pediculosis caporis is body head lice. So this might be like under the arms, or, you know, kind of in those crevices. Pediculosis pubis is pubic lice, okay? It used to be called, like, referred to as crabs, okay? All the same lice, okay? All the same bug, okay? Just different locations, okay? Lice, they have to have something to feed off of and to be able to get blood from their host. So if they wind up off the host and they're not able to get blood, then that's when lice dies. Okay. As far as treatment, there are oral treatments, but parents still have to do, especially if it's head lice, parents still have to do the combing, right? Combing the hair out, put the head lice stuff on, let it sit there, comb through every day. We have to put our stuffed animals and things in a bag, you know, an airtight bag, for a couple of weeks, so that way that lice can die off. Okay, vacuum things, wash things in hot water, oil our brushes. There's a lot of things that go along with head lice. So even if those kids are given an oral antiparasitic medication, they still need to be doing all of those other things, because it's not unlikely that some of those parasites have kind of fallen off into the carpet or off into the stuffed animals or in the bedding. And then those kids can kind of continually get head lice or pubic lice or body lice. Okay. So antiparasitics are what are going to be given for head lice. Scabies, very similar. Another parasite, very similar to, like I said, okay, now I'm itching my head. Very similar to head lice, except this is a mite, and it actually goes in under the skin and lays eggs. Okay. And then what you see, especially between like fingers and toes, as well as like armpits and groin area, you'll see that there too. What you see is as they burrow under your skin and they are laying eggs, you'll start to see kind of like a little brownish, blackish, red line. And so what is happening is they're not only laying eggs, but their feces is also kind of creating that line. Okay. So you are going to have, if you have a patient who has scabies, they're going to have really, really, really intense itching, mostly at night. Okay, whereas with head lice, it's itching all the time. It's going to be more active at night because this is when those mites are burrowing further. Okay. Like I said, moist body folds between fingers, between toes, armpits, under breast, groins, bottoms, all of those areas. Spread by close personal contact. So you touch bodies with somebody who has scabies for a short period of time, you can wind up with scabies as well. They are going to get permethrin cream. Okay, so this is going to be a topical. And everybody in the house needs treated. Okay. And the car. Okay. So they make some things that you can buy for car treatment and home treatments. Okay. Usually you treat them once and then you wait a week, just like with head lice, and then you treat again. Okay. Alrighty. We're going to talk about different types of burns. Any questions about anything before we start talking about the burns? No? Okay. All right, so burn types. Obviously, depending on what's causing the burn, you know, you're going to see a different kind of burn pattern. So thermal burns, those are going to be caused by fire or scalding vapors or liquids. So, you know, house fire, or toddler reaches up, there's boiling water, they reach up on the stove and they pull the boiling water over on themselves. That would be a thermal burn. A chemical burn is going to come from a corrosive powder or a liquid. So think about anything chemically. So like antifreeze, right? They spill antifreeze on their arm, or they're around a farming chemical like anhydrous. Oh, let's see, what's this thing? Oops. So they're around farming chemicals and they get some of that spilled on their skin, then that's going to cause a chemical burn. Electrical burn, that's obviously going to be electrical current passing through the body. Okay, so they stuck their finger in an outlet, or they stuck something metal in an outlet, and then that they had an electrical burn from that. Okay. With electrical burns, you'll see an entry site and an exit site. Okay. So depending on where that electricity comes in, it will come out another side. Sometimes you get concerned about muscular damage, depending on the area that the electricity touched and how it traveled through the body. Okay. A radiation burn, so that can be caused by x-rays. Okay. Or if kids are getting radiation for their cancer, they can get a radiation burn. Okay. A moderate burn. So that would be a partial thickness burn that involves 15 to 30% of the body surface. So burns are classified by how much of the body is involved and how many layers of skin are involved. Okay. So a partial thickness burn, that's not all the way through all the skin layers, but it's, you know, into the epidermis. So if 15 to 30% of the body surface is covered with those partial thickness burns, that's going to be considered a moderate burn. Okay. If it's full thickness, so it's all the way through that dermis and epidermis, then 10% of body surface will be a moderate burn. Okay. Major burns, that's going to be partial thickness of more than 30% of the body, or full thickness of more than 10%. Okay. Both are very, very much at risk for infection, right? Because that's an open wound.
I have a question. Do you use the rule number 9, I think it is, for like the kids with burns?
Yes.
You use the same thing? Okay.
Yep.
So that's what you mean by the moderate and the major?
Yep. And that's how you get your percentages, right?
Okay.
Yep. So like depending on where it's at the body, it's not always going to be cut and dry. Okay, if this arm is burned and this arm is burned, you know, then they have 10% each or whatever. But you have to utilize, yes, the rule of nines, which is in your book. Obviously, because kids are smaller than adults, they're going to be, you know, they're going to hit that rule of 9 a lot sooner. Okay. So like a tiny burn can on their, you know, upper chest or on their face can really escalate that percentage of their burn number. Okay. Because they have such a small body surface area compared to adults. Okay. So skin is thinner after burns, so, or on kids. So these kids will have more serious depth to their burns, and they need lower, like they'll be more likely to be burned at lower temperatures with shorter exposures than adults. Like adults can tolerate some heat for longer periods of time when compared to children. Okay. They also have an immature response system. So when they have those burns, they're more at risk for heart failure and shock. Okay. Obviously, the larger surface area that burn is covering, they're going to be more at risk for infection, heat loss, right? Because they're not going to be able to thermoregulate anymore in that area that's burned. And they're going to have more electrolyte and volume loss. Okay. Kids also have more of an increased metabolic rate. That's what that increased BMR is. So they'll need more protein and more calories than adults who have burns. Okay. The 6 C's of burn care. So look at your clothing, right? You don't want clothing that's sticking to the burns, but it needs to be protected from potential infection. Cooling that area, cleansing or cleaning that area. They may be adding a chemical to kind of deactivate that burn sensation when they're doing the dressings, covering that area with a dressing, and then pain relief, comforting. Burns are extremely, extremely painful. Okay. So kids with burns are that are in the hospital are likely going to be on IV pain narcotic medications. Okay. Okay, so emergency care of burns, obviously stop the burning process. That's the very first thing you want to do. Evaluate the injury and then cover the burn and get those kids to the hospital. The risk with burns, depending on the burn, obviously you get concerned about their airway. So did they inhale a chemical? You know, because they were in a house fire, did they inhale a bunch of smoke and they're going to have inhalation burns? So, you know, they're not going to be able to keep their airway very stable. Okay. Cyanosis, singed nasal hair, charred lips, stridor, those all can indicate that they've inhaled flames. Okay. So those are kind of some signs. If that happens, those kids are going to be intubated pretty much right away, just because they don't want to lose their airway, and having to do it when there's still a good shot at getting the ET tube in place is easier than having to do it when they're really struggling to breathe already. You're also going to establish an IV line really quickly because these kids are going to need fluids, blood work, and other body, you know, assessing other body fluids and lab testing as needed. And then they may also need an NG tube because some of that, you know, if they were a chemical burn, some of that chemical could be still within their stomach. So we're going to try and get that out of their stomach. Okay. So here's your little chart. It's not very good chart to Kayla, but This is showing those kind of burn percentages. Like I said, this picture isn't very good, but if you look up rules of 9 and the burn percentages for kids, you'll find better pictures on there. So these kids that are hospitalized with burns, they are going to be in a protective isolation. So you guys will be wearing gloves, gowns, maybe a mask. All of the things will be covered up so that way there's not more of a risk for infection. All instruments you will be using to do changes or anything like that will be sterile. So they'll get a new pack of instruments every time you're doing dressing changes. Okay. Ointments and all of that will be applied with a sterile glove or sterile tongue depressor. Okay. So you're not just kind of gooping it with a normal glove on there. It's all got to be sterile because infection is very, very likely in these patients. You also have to be careful when you're applying the ointments and things like that, that you're not affecting or worsening the risk of those new granulating tissues. So that new tissue growth that's happening, that you're not interfering with that while you're applying and doing the dressing changes on these kids. Dressing changes are going to be really painful, so those should be, pain medication should be given, you know, about an hour or 15 minutes, depending on what you're giving, before you start those painful interventions. That way their pain control is hopefully somewhat adequate before you're starting those interventions. The wounds will need to be cleansed and debrided. It depends on the type of burn and your orders, how often that will be happening. Usually it's once a week with some burns, but sometimes if it's not, you know, a really thick, full thickness burn, then it might be a couple times a week or even once a day. Okay. Loss of skin increases your risk of infection and fluid loss, right? So when those burns are uncovered, you know, that's what's happening. You're at an increased risk for infection, and also their increased risk for fluid loss because the fluids are essentially evaporating from those open wounds. Okay, another critical thinking question. So a school nurse for an elementary school must prepare an educational program for the school children on emergency responses to a burn injury. How would the nurse educate the children on this process? So what would be some things that you could tell these kids? If they have a burn injury, what should they do?
I guess to protect the burn, so
Yeah.
it don't get infected and stuff. You got to protect the burn.
Yeah, so let's say this kiddo is at school and they touch something hot and they have a burn on their hand. What would be the very first thing you would tell them or have them do? Stop touching that thing, right? Or unplug it. Like get them away from that. So get them away from the burn first. Okay.
It's like smoke, like if you see smoke.
Yeah, or if you see smoke, yeah, like don't go towards it. Teaching safety things like that. Yep. Running cool water over it, right? Doing something cooling, not too cold though, because then you can put them in shock. Okay. And then cover it, keep it protected. And then what's going to happen? They're going to go to the hospital, right? Yeah. So some education things. As a school nurse, you probably want to educate on some safety things, right? So not putting ourselves at risk for having chemical burns or having those, fire risk. So having fire alarms at home or fire detectors, smoke detectors at home to reduce the risk. If there is a fire, then at least the kids know, and they know to go down to the ground and crawl out so they're not inhaling smoke.
And lock up chemicals.
Yes, good. Yep. Electrical outlet protectors. School age kids, they're kind of past the age usually that they're messing with that, but crazier things have happened. So talk about those safety things with them as well.
And also how it's important to like make sure if they do get an injury to eat their food and stuff.
Yes. Yep. Yeah, because they'll need a lot of calories and protein to heal those injuries. Yep. They'll need like almost 3 times the amount of calories that we need, or than a typical child needs, if they have burns, especially if they're full thickness. Okay. Alrighty. All right, sunburn. So probably one of the most common types of burns, right? This can be epidermal to serious partial thickness burns with blisters. So there's different stages of sunburn, 1st through 3rd degree, okay? And that is just looking at the amount of skin layers that are affected, commonly caused by overexposure to the sun and not utilizing sunscreen, okay? To stop the exposure to the sun by utilizing sunscreen, but if kids already have burns, they should stay out of the sun, okay? Treating the inflammation with something like aloe vera, something calming to the skin, and then rehydrating that skin as well. That will help kind of get them through that sunburn process. Obviously, sunscreen, it helps you absorb some UV light, but it blocks those really harming sun rays that are most likely to cause sunburn. You obviously have to tell these kids to reapply sunscreen frequently, okay? Zinc oxide and titanium dioxide are the most effective types of sunscreen or sunblock, okay? So those are those thicker, really harder to rub in kind of sunblocks, okay? So sunscreen allows for some UV light to be absorbed. Sunblock blocks it totally. Frostbite. So this happens from the freezing of a body part, okay? A chilblain is a cold injury that comes with redness and then vesicles, so blisters, and then ulcerations, okay? And that occurs from vasoconstriction from the cold, right? We're going to vasoconstrict because it's really cold. In exposure to extreme cold, warmth of the periphery of the body are lost. So that way the core part of the body, the center of the body, can maintain the heat. But obviously, as people and kids are outside for longer in those extreme conditions, eventually the center will also the core temperature will also start to drop. Okay. So the head and the torso should try to be warmed first to ensure survival. So if you find someone outside in the extreme cold, trying to warm up their head, so put a hat on them and give them a like warm blanket around their torso. Okay. They make those like metal looking heat blankets. That's something that you could utilize as well. Okay. Now, a deep purple flush will appear with sensation, with the return of sensation. So as they're warming up, it'll be really deep purple looking, and then they'll start to have extreme pain. Okay. Eventually, if they continue to not have that recirculation happening of the frostbitten area, then they'll have necrosis and they'll have to have amputation to those extremities potentially. Okay. Okay, now metabolic condition. So chapter 31. Know these terms, okay? Know these objectives. Help this kind of guide your studying. Okay, so the endocrine system, this goes with your metabolic conditions, okay? So there's two interdependent control systems of the body. The nervous system is one, and your endocrine system is the other. So endocrine means ductless glands, so they don't have ducts. This is what regulates your metabolic processes. Okay. So the endocrine system is responsible for things like growth, reproductive hormones, your response to stress, and your maturation of your body and your organs and your growth. Okay. Studies that can help to diagnose any disruption in the endocrine system include x-rays, okay, because that can look at your bone growth and your bone age study and tell us if there's something going on to where your bone age is not the same as your numeral, your actual birthday. Okay. So there's some serum blood screening tests that we can do. So PKU or phenylketonuria, that is a test that's done on most newborn metabolic panels. Okay, so that's done very, within 24 hours of birth. Usually they are getting that blood work. Chromosomal studies, so if they've seen geneticists, they've had, chromosomal abnormalities that are affiliated with potential metabolic disruption. That's one way, another way to diagnose. Biopsy of the tissues, looking at your thyroid function, blood work, ultrasounds, so ultrasound of the pancreas, ultrasound of the thyroid, ultrasound of anything within the endocrine system to see if there's some abnormality in the structure. And then also a 24-hour urine specimen, because we can check and see, are we spilling proteins? Are we spilling glucose? Are we spilling ketones in our urine, which can be suggestive of an endocrinologic or metabolic disruption. Okay, Tay-Sachs disease. So this is a deficiency of the lysosomal beta hexosamide diastase. So it's an enzyme that is used to break down fat. Okay. So what happens is these lipid deposits start to accumulate in nerve cells, and then that leads to the physical and mental deterioration of these kiddos with Tay-Sachs disease. So these kids initially, healthy babies, growing great, and then all of a sudden they start to get all of these fat deposits in their nerve cells, and then their growth and their development just drops. Okay, they're no longer able to function how they were before. And these kiddos usually die around the age of 2 to 3 years. Okay. Most commonly in the Ashkenazi Jewish population. Okay. More risk if they are of that descent. And it's autosomal recessive. Okay. So that means both parents have to give you this trait. Okay. Not anything that we can do about it at this point, unfortunately. We don't know how to reverse this. Okay. So that's a hard one because, like I said, babies are normal until they have too many lipid deposits in their nerve cells, and then their growth and their mental deterioration starts. Hypothyroidism. So This is obviously low thyroid, so a deficiency in the secretion of thyroid gland. So whether it's thyroid stimulating hormone or your thyroid like T4 or T3. It can be congenital, so it can be something that babies are born with, which means that the gland is absent or totally does not function, or it's something that's acquired, so it happens later in life. More common, this is the most common endocrine disorder in children, is hypothyroidism. So thyroid hormone helps control the metabolism in the body. There's various signs that you would see in these kids. So mostly it's like hair loss, insomnia, aggressiveness, their schoolwork, you know, they're not going to be able to do as well. Their growth is going to start dropping off. Maybe they've had a significant weight increase. They feel like their heart's beating out of their chest or skipping beats. Those are all kind of signs of thyroid dysfunction. So you would want to get thyroid hormone levels. So though that would be blood work. Now on the newborn metabolic panel, there is hypothyroidism for searching for the congenital form of hypothyroidism. So if babies are born with hypothyroidism, then that should be found on that newborn metabolic screening panel. Now, if it's an acquired form and it happens later on life, that won't be a positive finding on their newborn metabolic panel. Okay. The goal is to reverse those symptoms by giving them thyroid hormone. Okay. So they'll be on lifelong thyroid hormone replacement. Once you get them on thyroid hormone replacement and their levels, you know, normalize, then a lot of times these kids can gain back what they've lost. So they can, you know, they're no longer having the troubles with their schoolwork. Their hair begins to grow again. They're able to sleep better. They're not having those chest pains or those palpitations. And they're able to
then a lot of these kids can back.
They're able to grow along their curve better. Okay, diabetes insipidus. So this is hereditary or acquired. So if it's hereditary, it's autosomal dominant. So one parent can give that gene and this kid can have diabetes insipidus. Okay. Or if they get into a traumatic injury and they have a head injury, then it can become an acquired condition. Okay. This is posterior pituitary hypofunction. Okay. So the posterior pituitary gland is not functioning like it should. So it's resulting in a decreased secretion of vasopressin. So vasopressin is also called antidiuretic hormone. So with antidiuretic hormone being decreased, they're going to be peeing all the time. Okay. They're going to be peeing so much that that urine doesn't even concentrate, essentially, because they're just peeing. This is not like diabetes mellitus, okay? Not the same thing, okay? But because of that decreased secretion in vasopressin or antidiuretic hormone, these people will be peeing a lot, okay? So they're very much at risk for dehydration. Okay. Okay. Nursing student is considering working for a pediatric endocrinologist after graduation. She's concerned about her ability to gain sufficient knowledge to respond to questions from parents and their patients and their parents about various metabolic disorders. What could the student do to acquire more knowledge in this field? And what will the student discover in terms of the role of the endocrine system? So what could you do to get more knowledge of the endocrine system?
Study it.
Yeah, right. Read about it. Yeah. Maybe try to do your like preceptorship or your job shadow, your clinicals in that area, right? To get some more exposure. And what do you think, as you're studying and learning about that, what do you think you would learn about the role of the endocrine system as far as how it affects the whole body? Yeah, medical journals talking about specifically the endocrine system. Yeah, and findings with that. So the endocrine system, if there's any dysregulation in that, it can affect
Produces hormones.
all body systems, right? So if there's dysregulation in the endocrine system, it's going to affect your growth. It's going to affect how you mature. It's going to affect your reproduction. It's going to affect your puberty. It's going to affect a lot of different body systems if there's an issue with your endocrine system. Okay. Okay. Diabetes mellitus. So remember, this is different than diabetes insipidus. Diabetes insipidus is an issue with vasopressin not secreting enough. Okay. This is different. This is with our blood, looking at blood glucose levels. Okay. So the body is unable to properly use or break down carbs. Okay. So type 1 is an autoimmune condition. So there's genetic predisposition for these kids to get type 1 diabetes. Okay. Kids or people with type 1 diabetes, they're going to be on insulin lifelong. There's no reversal of it. It's lifelong. Okay. Type 2 is insulin resistance. So this is more common with people who are obese or have sedentary lifestyles. Okay. With diabetes, your body is unable to store and use fats properly, so you also have a decrease in protein synthesis. Okay. Type 2 is potentially reversible. Okay. So if somebody's diagnosed with type 2 and they get on, like metformin or an oral pill for a while to help control kind of that insulin resistance, and they start working out and they're eating healthier and they're losing weight, then type 2 can be reversed. Okay. But type 1, it's autoimmune, it's a genetic condition. So once you have that diagnosis, you're on your insulin for life. And it's insulin injections, not oral pills or anything like that with type 1. To diagnose diabetes mellitus, they're going to get a random blood sugar. Okay. So fasting blood sugar, if it's over 126 milligrams per deciliter and they haven't had any calorie intake for 8 hours, you're able to diagnose diabetes. Okay. If you do a glucose test and it's over 200, that's a diagnosis of diabetes. Or if you get a glycated hemoglobin, so a hemoglobin A1C, that's probably the most common type of diagnosis. So that's looking at your average blood sugars over a 3-month period. If it's 12 or higher, then that's a diagnosis of diabetes as well. Now, to diagnose type 1 versus type 2, there's very specific testing that endocrinologists will do to make that determination. But just for nursing knowledge, if you see a random fasting glucose over 126, you kind of can tell that kiddo is probably going to get a diabetes diagnosis, or that adult. Okay. So type 1 diabetes, it's one of the most common metabolic disorders in kids. It's about 1 in 300 cases now. After COVID, there's been a lot more diabetes, type 1 diabetes diagnosed, interestingly enough. It almost increased after COVID by 136%. That was the last study that I saw. So it's significantly increased as an autoimmune condition after COVID. Can occur at any point in childhood, most commonly between the ages of 5 to 7, because they're having increased risk for infectious diseases, and they're, the stress of getting used to schoolwork and all of that. And then also the other age ranges from 11 to 13. So they're going through puberty, they're having rapid growth, they're having increased emotional distress. Their insulin is working with their sex hormones. So that can kind of throw things off and wind kids up getting a type 1 diabetes diagnosis during those age groups. It's hard to manage type 1 diabetes during childhood because of the energy that's expended by these kids. There's different nutritional needs, obviously, based on age and growth. Okay. So usually initial diagnosis happens when those kids are in DKA. Okay. So they're spilling those ketones. After initial diagnosis, they get stabilized on their insulin. That's called the honeymoon period. Okay. And then their insulin's going to decrease. Their insulin requirements are going to decrease because they're starting to feel well. Okay. And then what happens is parents may, or the child may kind of back off on doing their insulin, and then they're going to go the other way. Their blood sugar is going to get kind of wonky again. Okay. So the important thing to do with type 1 diabetes is educating parents to make sure that they're doing their insulin as prescribed. Okay, classic symptoms of type 1, specifically diabetes: polydipsia, so they're always hungry, or excuse me, they're always thirsty. Polyuria, so they're drinking or they're urinating frequently. And polyphagia, they're always hungry. Symptoms happen a lot more quickly in children. Usually they've had some weakness, some lethargy, and weight loss. Okay. In adolescent girls, you'll see more frequent yeast infections, and their skin will become really dry. You're going to see glucose in the urine. You're going to see hyperglycemia, okay, because that glucose can't help deal with the insulin, okay? So that glucose just hangs out in the bloodstream instead of attaching to insulin and being processed like it should be, okay? Cells are going to use your body or your protein and your fat storage, okay? They're going to get rid of the protein and the fat for energy, okay? And because of the lack of glucose in the cells, that's going to trigger that constant hunger, okay? So the body's going to feel like it needs to increase that glucose intake further, but then that makes the glucose levels in the blood higher. Okay, so a 10-year-old boy has been diagnosed with type 1 diabetes. What should the nurse recommend that he do about his condition?
Understand the signs and symptoms, like when he's low.
Yeah. Or
This
high,
could-
right?
Yeah.
Yep.
How to test himself.
Yes. Yep, because he's 10, so he can do that, right? He can be taught to do that. A lot of times these kids are on continuous glucose monitoring systems. So they have, like, they just do the one needle and it lasts them the whole week or so. A lot of them have insulin pumps as well. So how to use your pump to give you your insulin. Yes, keeping a snack or some candy close by if he's low. Yep. What about, oops. Goodness. What about like dietary stuff, right? Yep. Carb counting. You're probably gonna have to do that. Okay.
Stay away from the sugar.
Yep. The difference between long-acting insulin and short-acting insulins, right? gonna have to teach them that. If you use a short acting one, you want to make sure that your food's right there so you don't bottom out. Good. Okay, DKA. So signs of DKA or diabetic ketoacidosis. So ketonuria, so ketone spilling in the urine. That's one of the classic signs of DKA. You're going to have a decreased bicarb. Okay. So you're going to have decreased CO2 levels and a low pH. This is where that fruity breath starts. Okay. They're going to be hypertonic with their dehydration because that glucose is just hanging out in the blood instead of going into the cells. A lot of times there's nausea. They're going to have altered levels of consciousness. Okay. DKA can start really mild and it can get very severe, and that can happen within hours or days. Just kind of depends on the kiddo. Usually with kids, they can go into DKA and it can become very severe very quickly because they just don't have the reserves that adults do. So treatment goals of diabetes, obviously ensuring normal growth and development by making sure that you're controlling their sugars. Teaching these kids how to cope with their chronic illness, allowing them to have, as normal of lives as they can. So participating in sports and all of that, but also knowing that if they are in sports, their insulin demands or dosages may need to be changed a little bit. Okay. Well-balanced diet, precise insulin administration, which we've talked about, and regular exercise is necessary in these kids. Now, in educating parents and the children, obviously in teaching parents, there's going to be different ages, financial backgrounds, beliefs, all of that. So you have to take that into consideration when doing your teaching plans. Okay. Now, in some cultures, our insulin is derived from pork. So pigs. Okay. So now in some cultures, they cannot eat pork and they cannot take in pork. So you may need to find another form of insulin for them to utilize. Okay. So that might be a concern. So if kids are coming in and they're in DKA a lot, and they're of Jewish descent or Arab descent or something like that, having that conversation that, hey, your insulin is not pork-based, or it is pork-based, let's find you something else so that way you don't have to be worried about that. Okay. So teaching, here's all the things that you should teach kids about. You guys can read all of that. Okay. We've kind of already gone through it all. Okay. Insulin administration. Like I said, a lot of times kids now are getting the continuous glucose monitors, which is what this is showing. So they put this on, it lasts a week usually, and it checks their blood sugars. Like at any point you can get on the app on your phone and you can know what your blood sugar's at. Okay. And then a lot of times if they have those continuous glucose monitor or a glucose monitor that's, on their skin, they also have an insulin pump. Okay. So essentially they're able to give themselves insulin, dose themselves based on what their CGM or continuous glucose monitor is giving them for numbers for their blood sugars. Now in the hospital setting, a lot of times insulin pumps and CGMs are not utilized. So we're checking blood sugars, with finger pokes, and then giving insulin in injections forms. Okay. Insulin shock. So this is hypoglycemia, right? So when the blood glucose levels in the blood become too low. So this can be caused by too much insulin. Okay. Can be worsened by if these kids decide to You know, give themselves their dose of their short acting, eat a quick little snack, and then go do their soccer practice. That could potentially lead them to insulin shock. Or if they're not feeling hungry, so they're just not eating as much, or they're giving themselves too much insulin. Okay. So their immediate treatment is going to be giving them sugar in some form. Okay. And glucagon, they should have glucagon with them if they have severe hypoglycemia. Okay. Should start to feel better within a few minutes of getting that sugar. Okay, Somogy phenomenon. So this is rebound hyperglycemia, okay? So the blood sugar levels were lower to the point where the body then starts regulating those hormones, and then that there's a spike in the glucose that's released from the muscles of the liver and the cells of the liver and the muscles, okay? So then that's going to rapidly raise the blood glucose levels. Okay. Something that can just happen based on the counter-regulatory hormones. Okay. Type 2 diabetes, we kind of already talked about this, most commonly from fat-rich diets, right? So then it results in insulin resistance, low physical activity, and obesity is increased risks. Okay. Insulin may be used, otherwise oral hypoglycemic medications like metformin will also be used. Okay, we aren't going to get to the childhood communicable diseases and bioterrorism, but you guys have the PowerPoint, so look through that. Okay. Childhood communicable diseases like are things that we can vaccinate for: chickenpox, measles, mumps, rubella. I don't know if you guys have seen about the measles outbreak that's going on right now in Texas. Hang on one second, my camera went. But you know, because people are nervous to vaccinate now, and there's been a drop in that herd immunity, we're going to start to see some of those communicable childhood diseases come back. Okay. So read about that. That's chapter 32. Okay. You have your exam next week, exam 3, last one. Okay. So make sure you use your study guides, your Kahoots, and the PowerPoint and the exam reviews. Okay. If you have any questions or anything like that, you can let me know. Okay. All right. Anything else that you guys need? No?
Thank you.
Yep. Have a good day, guys. Michaela, do you need anything? Okay. Alrighty. So just when you hopped on here, you were unmuted, and there were some curse words that happened.
Yeah, I want to sincerely apologize. And it was not like personal. I was just, because I knew my camera was off, and I was just like, oh my gosh, I can't be here. But I'm really sorry. Like, I'm like genuinely very embarrassed. And I'm just sorry. But
Well, was it about me, or was it about the fact that your camera was
no. It was like literally two separate things, because I was late getting on because my neighbor was causing drama with the parking spot, and then I'm just like, I know my camera wasn't on at the same time, so I'm just like, please don't call my name. So I was just having a rough morning, but I wasn't like, trust me, I'm very sincerely embarrassed about the whole thing, and it won't happen again. I do need to make better efforts on being more organized with the whole online classes. And my son's like 6, so he's still like home. So it was just
A lot.
a warning. Yeah.
Yeah. Okay. Well, just make sure, well, obviously we shouldn't be saying things like that anyways, but
Yeah.
make sure if something like that's gonna be said that you're muted.
Yes, ma'am. I got
Okay,
you for
in the
sure.
future.
Yeah. Yep. I'm
Okay.
just, trust me, I'm like, oh my God. Oh my God. It's just been a day and a time.
I understand everyone can have days, so that's acceptable, but let's just not make it a habit, okay?
Yep, for sure.
Okay. Alrighty, have a good day. Good luck
Yes.
on your exam, studying for your exam and things, okay?
Yep. Thank you.
All right, yep, take care.
You too.
Bye.
Bye.